Thank you to the SAGES Organizing Committee for having us here today to present our work looking at frailty on patients undergoing surgery for colonic diverticular disease. None of the authors have any relevant disclosures. Several definitions for frailty have been suggested. Conceptually, frailty may be defined as a low state of physiologic reserve that ultimately results in a lack of ability to withstand acute stressors. In reality, however, frailty is a complex, multidimensional, and often fluid state of low physiologic reserve that is associated with poor outcomes following a variety of treatments and interventions across numerous different patient populations. There are over 70 indices that have been reported in the literature for screening and identifying frailty, including anywhere from 1 to 90 items, some of which are validated and some of which are not. The Modified Frailty Index 11, or MFI 11, as you can imagine, includes 11 items. They're listed here. And this index was designed to allow for the identification of frailty in the clinical setting by counting the number of items present in a patient's medical history and dividing it by the total number of items in the index. This was validated by Vilinovich and colleagues in 2013 using a large ACS-NSQIP database study of nearly 1 million patients. This has since been studied across numerous large population-level databases, most commonly the ACS-NSQIP database, and studies have pretty unanimously demonstrated that increasing MFI has been associated with increased intraoperative and postoperative complications across numerous surgical populations, including patients with colorectal cancer, endometrial cancer, gastric cancer, and more. The MFI 5, which is an offshoot of the MFI 11, has been used to identify frail patients undergoing surgery for colorectal diverticular disease, but the MFI 11 has never been used for this patient population. As such, we designed this study to compare frail and robust adult patients as defined by the MFI 11, registered in the National Inpatient Sample from 2015 to 2019, undergoing operative intervention for left-sided diverticular disease in terms of postoperative morbidity and mortality, as well as healthcare resource utilization. This was a retrospective population-based cohort study that utilized the NIS from October of 2015 to December of 2019. This is the largest public all-payer inpatient database in the US. It includes hospitals covering more than 97% of the US population and records approximately 7 million discharges annually. We utilized ICD-10 codes to identify patients with either uncomplicated or complicated diverticular disease that were undergoing left-sided colonic resection in either the elective or the emergent setting. We did exclude patients with diverticular bleeds. We also used ICD-10 codes to identify and calculate the MFI for each patient included in our cohort. The patients were then stratified according to frail and robust status with an MFI cutoff of 0.27, which has been previously validated, which essentially means that if a patient had 3 or more items from that list that we identified previously, then they were identified as frail. The primary outcomes were in-hospital postoperative morbidity and overall and mortality, and secondary outcomes included system-specific morbidity, length of stay, inpatient cost, and discharge disposition. We utilized descriptive statistics to describe our study cohort, and then we performed linear and logistic regression models for continuous and categorical variables, respectively, adjusting for the variables that you see here. In total, we included 2,632 patients that were identified as frail and 24,194 patients that were identified as robust. The frail patients were older, they were more likely to be female, they were more likely to have a body mass index of greater than 30, they had higher Charlson comorbidity indices, and they were less likely to have private healthcare insurance. Just over 60% of patients in the frail group had complicated disease as compared to just under 50% in the robust group. Correspondingly, more patients in the frail group had emergency surgery. Approximately 70% of patients in the frail group had a resection with primary anastomosis plus or minus proximal diversion, and that compared to 83% of patients in the robust group. And the majority of patients in the database had open surgery. As you can see, mortality for in-hospital postoperative care was low in both groups, and on adjusted analyses, there was 116% increased odds of postoperative mortality in the frail group. Similarly, overall postoperative morbidity was significantly elevated in the frail group with an odds ratio of 1.84 and an absolute difference of approximately 25%. This was attributable to all system-specific complications, including gastrointestinal, genitourinary, cardiovascular, respiratory, and infectious complications, with frail patients having higher incidences of all of these outcomes, with odds ratios ranging from 1.5 to 4.5 and corresponding 95% confidence intervals excluding the line of no effect. In terms of healthcare resource utilization, patients that were identified as frail had a half a day longer postoperative stay in hospital, had approximately $25,000 more spent on their inpatient care, and were half as likely to be discharged home as compared to patients in the robust group. All in all, we believe that this large population-level retrospective cohort study demonstrates fairly convincing evidence that patients identified as frail as per the MFI are at increased risk of postoperative morbidity and mortality that is both clinically and statistically significant. Frailty is also associated with increased healthcare resource utilization. There are several limitations to bear in mind when thinking about these results. Firstly, the MFI-11 has been criticized for its inability to potentially completely capture frailty as a concept. While it does measure a number of different comorbidities that contribute to frailty, whether it is the best tool at doing so is definitely a matter of debate. It also assigns the same number of points to each item in the index, and I think we can all probably agree that medicated hypertension and COPD don't necessarily contribute equally to frailty. I think the biggest issue with this study is residual confounding. The NIS doesn't necessarily have all of the baseline covariates that are important for these outcomes, such as nutritional status, smoking status, HG classification, and more. And lastly, it's important to bear in mind that the NIS only has access to inpatient data relevant to the index stay in hospital, and so we're missing some patient-important outcomes such as readmission and stoma-free survival. In terms of future directions from a research perspective, I hope that future studies can critically evaluate our current frailty indices that are available to potentially identify an optimal index, and then subsequently further large prospective studies evaluating preoperative optimization and its impact on frail patients, I believe is necessary. Clinically, I think that surgical residents and surgeons should continue to screen for frailty in their preoperative clinics and hopefully subsequently implement pragmatic and cost-effective preoperative optimization strategies for these high-risk patients. Thank you, and happy to take any questions at this time.